Organizing Secretary, Honorary Editor IPSKC, Dr. Jagdisha T, Organizing Chairperson, Head of the Department Psychiatry NIMHANS, Dr. Geeta Desai, Professor of Psychiatry NIMHANS, Organizing Co-Chairperson for this workshop. I welcome our resource person and mentor for today's session, Dr. Ravi Philip Rajkumar Sir, Professor of Psychiatry at JIPMER, Puducherry. I welcome our moderator for today's session, Dr. Saraswati Antanagi, Senior Consultant Psychiatrist, Health and Family Welfare Department, Belgavi. I now request Dr. Saraswati ma'am to introduce our resource person and moderate the session. Over to you, ma'am.
Good evening, all. Uh, Once again, I welcome you all for this peer review workshop. We have our IPSKC president here, members of the journal club, IPSKC members, and all the participants of the peer review workshop, and our important person, Dr. Ravi Philip Rajkumar, the resource person for today's presentation. Dr. Ravi Philip Rajkumar is a professor in the Department of Psychiatry at the Jawaharlal Institute of Postgraduate Medical Education and Research, JIPMER. He has obtained his MD in Psychiatry from NIMHANS, Bangalore, and has been a faculty member at JIPMER since 2010. His areas of interest include psychopharmacology, comorbidity in psychiatric disorders, and studies of the correlates of mental health and mental health service delivery at a cross-national level. He is a member of the editorial board of several journals in the field of psychiatry, including BMC Psychiatry, the Journal of Psychosomatic Research, and Brain and Behavior. He has published over 170 papers in peer-reviewed journals to date. Sir is not new to our journal club, our Journal of Psychiatry Spectrum. He has been a resource person previously also for our workshops, and he has been instrumental in providing information to all the participants before also. Is not a new person, and it's a privilege to be moderating his session today. I'm honored, sir. And today, sir will be speaking on what are the important observations the reviewers need to look in this particular type of study, like case control study, which includes like study design, clear definitions about cases and control, selection of controls, blinding, and many other factors. Dr. Ravi Philip Rajkumar will provide us with an insight into stepwise reviewing of case control study. Over to you, sir.
Thank you very much, ma'am. It's a pleasure to be here with everyone. And, as ma'am said, today what we are going to be discussing is basically walking stepwise through the process of reviewing a particular type of study, and more specifically a case control study. So, before I do that, I would like to start with a bit of humor. Okay. Now, before I started doing this workshop, before I started doing my own preparation, what I did is I did what everyone else does nowadays, which is, take the paper, put it into an artificial intelligence app, a large language model, and ask it to give its input or its feedback about the paper. So let's have a look at what, have all of you read the paper? Has everyone read the paper which was allotted for today's session, or are we going to read it now?
Participants are expected to read and present.
It's all right. Even if some people have not read, let us just look at this beautiful review report that was prepared by GPT-3. Okay. So he's saying, all right, let's dive into a structured peer review. And if you see, it's very impressively, very neatly written. It's giving you a summary of the article. What's the topic? What's the design? What is the sample, sample size? What were the key results and what were the conclusions? And then it lists out the strengths, both in terms of methodology and in terms of statistical analysis, and the weaknesses. And then it says, how does this paper contribute to the field? So it's giving you both the positives as well as the negatives of this paper. And it gives recommendations, 5 recommendations for what the authors have to do if they're going to revise this manuscript and resubmit it to a journal. So they say overall, this is a good review paper, and the main issue, this is a good paper, and the reviewer's only comment is that the interpretation of the results is not all that great. Now, looks like a very good review, doesn't it? Does anyone think that this review is well written? I think we can all agree. No, it's written in very good English. It's got all the subheadings. It covers most of the key issues. Does anyone think that this is not a good review? Anyone? Okay, now it would
Participants
be,
can enter in the chat box, please.
you can type in the chat box. Let me see some of your comments before I give you my comments. Okay, so one comment is that major and minor comments should be mentioned as a separate column. That's a very good observation. We'll be coming to that later when we talk about how to actually structure the report, because different journals ask for the report to be given in different formats. Some will want major and minor corrections. Some will want it section wise. Some will want an unstructured report, and you have to give it your own structure. But, someone else has said it looks well structured. So writing wise, English wise, I don't think there's anything wrong with this report. Probably it does a lot better than most of us would, because for most of us, English is our second language. But if you actually were to sit and read the paper line by line, in the light of what a case control study is actually supposed to do, and also in the light of what we already know about the relationship between these two conditions, hypertension and Alzheimer's disease, you will find that this review just scratches the surface. It's a very good review, but it's also a very superficial review. It would be like if you ask somebody to go and watch a movie and write a review about the movie, and they said the costumes were nice, the special effects were good, the story was good, the songs were nice, but some of the things were unrealistic. Suggestion to the filmmaker would be to make some of the scenes more realistic. It is absolutely correct. The nothing that has been said by that reviewer would be wrong about that particular movie. But you don't know anything about that movie after reading that review. You haven't understood whether you would want to go and watch that movie, or whether you would want to, avoid it at all costs and spend your money on something better. Likewise, this review tells us, that there are certain pros and cons of this paper, but it doesn't tell us as a journal editor whether we want to accept it or send it for revision or reject it outright. It doesn't tell us as, the author, how exactly we're going to correct our paper. Do we really just need to correct a few words in the discussion? Is that enough? Well, so now let's look at the paper itself. We're going to go through it, if not exactly line by line, at least section by section, and see what we can make out of it. So this is the paper. Okay, let's start with at the very beginning, a title. Okay, and before we come to the title, I'm sure all of us know what a case control study is, right? Everyone knows what it is. All of us have been learning about case control studies from the time we studied our third year MBBS and we picked up our textbook of preventive and social medicine. But if any of us, want a bit of a refresher, fortunately, we live in the information age. There are a lot of sources where you can read up about case control studies, and I would just show you one of them. Is this visible to everyone?
Yes, sir, that was visible.
That was visible. Wait, I will just open it. Okay. So if you look at this is a chapter from a handbook that is available on the WHO website. There are many similar manuals that you can find, for example, on the, Equator website, or on the, for example, even the Government of India has material, which basically tells you what a case control study is. So to sum up, to put it in very simple terms, what is a case control study? It's a study where you take two groups. One group of people has a particular disease or a particular condition. In the case of this paper, the condition is Alzheimer's disease. And it takes another group of people who do not have the disease. In the case of this paper, it would be they don't have Alzheimer's disease. They are called the controls. And then what you do is you compare in each group what is the frequency of a particular risk factor or a particular factor that you think may be associated with this disease. In the case of the paper that we are reviewing today, the factor that we have got under consideration is systemic hypertension in midlife. So our theory is that if a person had hypertension in midlife, they are more likely to have Alzheimer's disease later in life. And so what do? We take two groups, one group of people with Alzheimer's disease, one group of people without Alzheimer's disease. And then we check in each group what is the frequency of hypertension. And then we use certain appropriate statistical tests, which again, all of you would remember from your medical college days, the odds ratio or, the cross product, to find out whether the group that has the disease is more likely to have that particular factor than the group that doesn't have the disease. And if it is significantly more in the case group than in the control group, then we say that this factor may be associated with or may be a risk for having that disease. So suppose we find that systemic hypertension in midlife was significantly more common in the group with Alzheimer's disease than in the group without Alzheimer's disease, the control group. We would say that yes, systemic hypertension may be a risk factor for Alzheimer's disease. Also far well and good. But of course, even in this case, we cannot make a clear causal inference because remember, a case control study is a cross-sectional study. There are always certain types of bias that the study is open to. We'll be talking about that later. But for the time being, all we need to remember is there are cases, there are controls. We compare the frequency of one or more risk factors or exposures between these two groups and see if it comes out significantly more in one group than the other. So now we come back to the paper. Okay. So let's say we look at the title of the paper. So it says hypertension in midlife leads to Alzheimer's disease in older adults. Now, can any of you tell me what the flaw is in this title? Those of you who remember the AI review will notice that the AI review also pointed out this error, but I'm sure all of you could do it. So what is wrong with this title?
Type of study is not mentioned.
Excellent. So first and foremost, all guidelines nowadays, for whether you take the stroke guideline for observational studies or, the PRISMA statement for systematic reviews or, all these guidelines say that you must mention the study design in the title. If it's just a case control study, mention that it's a case control study. If it is some refinement of a case control study, like say, for example, a nested case control study, where basically you take case control data from an existing cohort study, then you mention that it's a nested case control study. In this case, you should at least mention those three magic words, case control study. What else looks wrong with this title?
Population is not mentioned.
Okay, the population is not mentioned. It's sort of mentioned. It said that it's older adults, So that is sort of mentioned, Of course, you could refine it. You could say older Asian adults or older men or older women. But if you're just interested in older adults, it's still sort of mentioned here. So that's okay.
It isn't
Again,
mentioned
look at
geography.
that.
Sorry.
No mention of
Duration.
Whether
of
it's in India.
duration. Whether it's in
Whether
India
in
or
India
Age.
or yeah.
Okay, one at a time, so a good point, is it in which country? Of course. But, we assume that something like hypertension linked to Alzheimer's disease is not going to vary much between India or Vietnam or South Africa or the United States. So yes, it would be good to mention, where the study was done, because there would be other confounding factors involved, but it's not a major error. It is an error, yes, it's not a very major issue. What do you think about this whole thing that hypertension in midlife leads to Alzheimer's disease in older adults? Does that sound right to you from a scientific perspective?
There is a statement in the chat box saying causal inference is made.
Exactly,
Yeah.
So that's a very good point, Causal inference has been made. In a case control study, as far as possible, we have to be very cautious about attributing causality. We can identify correlations, we can identify associations, but then we would need to confirm those causal associations using some other study design, like, for example, a longitudinal study. So it's better to say hypertension in midlife is associated with, or is linked to, or is a risk factor for Alzheimer's disease in older adults. So straight away, we have found some errors in the title, not very major errors that can be corrected by revising the manuscript, but which were not picked by our AI friend. So are we feeling better about ourselves as the human species now? I hope so. Okay. Now there are some other things that have been left blank because, of course, this is a trial manuscript. Like author, it's just an example manuscript. So things like authors, affiliation, corresponding author, contact details, have not been mentioned. Funding has been mentioned. Trial registration has been mentioned. Ethics approval has been mentioned. And some would want you to even have a statement on conflict of interest here. Some journals want it at the end, some want it at the beginning. So that depends on the journal format. Know your journal's format before you write the peer review report. When I started doing peer reviews, I used to do that. I would start my report by saying conflict of interest is not written, but then I would see that the journal wants it to be mentioned right at the very end. So we'll see. We'll see if it is mentioned anywhere. If it's not mentioned, remember that all manuscripts that report original research have to mention conflicts of interest. That's very important. Then let's look at the abstract. The abstract has sections. It has background, methods, results, and conclusion. Is this a good structure for an abstract? What is the standard structure that we want for an abstract? What is that acronym that all of us have been taught? We've been taught to write it as IMRAD or IMRAD or however you want to pronounce it. No? Introduction, methods, results, and discussion. And they have followed that. Introduction can also be called background. Methods are very much there. Results are there. And this conclusion, probably that word should be replaced by discussion and conclusions. Because before coming to a conclusion, you have to have a discussion. Some journals, like for example, let's say you're submitting this paper to a journal like Journal of Affective Disorders, will also want you to mention strengths and limitations in a separate paragraph, both in the abstract and in the paper itself. So you have to again know what the journal's style or what the journal's recommendations are. But by and large, this is okay. The structure of the abstract is fine. It's IMRAD. There is background, there is method, there is results, and there is some discussion. Let's look at the backgrounds. Take the very first sentence. Midlife hypertension is a well-established vascular risk factor. Okay. Do you find something wrong here? Yes, somebody has posted IMRAD over there. Very good. Okay. Can you find something wrong with that first line? The very first line. Very good. So what is midlife should be mentioned and for what? Excellent. So that first statement is a bit vague. First and foremost, midlife is a very broad term. Different people define it in different ways. Sometimes you can define it in the paper and say that, or you can just put it in brackets and say, this to this years, but you should define a term when you're using it. Hypertension, again, some people who are very, pedantic about the English language would say, mention that it's systemic hypertension. We are not saying that pulmonary hypertension is a risk factor for Alzheimer's disease. And vascular risk factor, again, is a very broad term. Vascular risk factor means it is a risk factor for vascular disease. What vascular disease? Peripheral vascular disease, cardiovascular disease, cerebrovascular disease, we don't know. And that doesn't really have anything to do with dementia unless we're talking about vascular dementia. So it might be better to say midlife hypertension is a risk factor for dementia or is a risk factor for cognitive impairment in late life. It's not even said whether it's a risk factor for dementia in middle life or in late life, So you could correct the statement by saying hypertension in middle age, in brackets, age 40 to 60 or age 30 to 60 is an established or is a known risk factor for cognitive decline or cognitive impairment. The next part of the statement is okay, but its long-term contribution to Alzheimer's dementia remains incompletely understood. Is that statement true? Are any of you aware of any review articles or papers on the links between systemic hypertension and Alzheimer's dementia? So somebody has written hypertension is a risk factor, midlife is vague. Okay, and we don't know. So this is where sometimes when you do a peer review, it helps to also do a little review of literature. I'll be coming to that when we go into the text of the paper. Then we see a statement that while epidemiological and mechanistic evidence suggests that vascular dysfunction in midlife may accelerate neurodegenerative processes. I think I've lost most of you by reading such a long sentence. No? So first and foremost, the sentence is too long. Abstracts have to be crisp and precise. So this could be broken up into shorter sentences. You could say epidemiological and neurobiological research suggests that systemic hypertension is associated with neurodegeneration, or vascular dysfunction is associated with neurodegeneration, full stop. Then you write the next sentence saying that large-scale studies or, case control studies with long exposure periods are limited or have not yet been conducted. Okay, so that those two sentences, though they are okay in their own right, can be broken up into at least two or three shorter sentences. When we come to the methods, it starts with, we conducted a nationwide retrospective case control study using health and administrative registers accessed through so and so. Okay. Now, again, here, some journals will differ with you on this style. Some will say, don't use we. They will say, a retrospective case control study was conducted. Or you have to say, this study is a retrospective case control study, whereas some journals will allow you to say we did, or our team, or our unit conducted this. Then we come to the case definition. So they have said cases were adults aged 65 years and above with specialist confirmed Alzheimer's disease diagnosis. Okay. Do you see anything wrong there? Remember, in a case control study, defining the cases, defining the controls, defining the exposure is very important. If you have not done that properly, your entire study may be flawed. So what do you think about this definition of the cases? They have said adults aged 65 years and above with specialist confirmed AD diagnosis. Is this okay? Are you able to identify from the statement that cases are people with a particular disease?
There's a comment in the chat box.
Exactly. So you are absolutely right, because if you read the very next sentence, the definition of the exposure is beautiful. They have said it is defined, they have given the age group, midlife is 40 to 55. They have said ICD-10 criteria, the blood pressure reading should be this much, or they should be taking some antihypertensive medication in the long run. So the exposure has been defined very, very well. The cases have not been defined so well. They should at least say that Alzheimer's disease diagnosis as per NINDS, whatever criteria, or ICD-10 criteria, some criteria have to be mentioned, or some standard definition has to be mentioned. And then it should also have they defined the controls in this abstract? Have they told you who the cases are? They've told you the cases. Have they mentioned anything about the controls? Not at all. So we can't really call it a case control study unless everybody is saying no. Right. This is something that even ChatGPT didn't pick up. The abstract is not telling you who the controls are. So were they taken from the same, database or from a different database? Were they adults aged 65 years with no dementia? Or were they adults aged 65 with mild cognitive impairment? Or were they just any old 65-year-old adults, randomly taken? Or were they matched for age or gender or socioeconomic status? The definition of the controls is as important as the definition of the cases. I'm always reminded of a study that, was done when I was an MD resident. A person who was just designing his protocol came to me and said, I'm very interested in doing research on the, the psychosocial aspect of the tsunami. And I said, okay, how are you going to do it? He said, I'm going to do a case control study. And I said, okay, the exposure is going to be whether they were exposed to tsunami or not. And I said, which are your cases? Which are your controls? He said, cases are fishermen in, the particular village who are suffering from post-traumatic stress disorder. Very good. Cases were fine. What is your control group? He said, my control group is my colleagues, students who are studying MD or MSc or MPhil or whatever in my institute. Now, do you see the flaw in this? The cases and controls have to be at least drawn from the same or similar population. They have to be sort of comparable. You take one group of, high income, well-educated students with no exposures, another group, who have all been exposed to the, earthquake or tsunami and have post-traumatic stress disorder. You're obviously going to not get a very good result out of the study. So the control group has to be defined as carefully and as precisely as the case group. Otherwise, you're going to get into trouble. Then they have mentioned something else. Okay, they've said logistic regression models, estimated, unadjusted, and adjusted associations. Is logistic regression the normal statistic that we use for a case control study? No. We usually start with simpler statistics like the odds ratio or risk ratio or cross product. And then after doing that, if you want to do a sensitivity analysis by stratifying, let's say hypertension, which is mild, moderate, severe, or hypertension for less than 5 years, more than 5 years, you can do it. So logistic regression, again, should raise a bit of a red flag here because it's not a commonly used test that we use in a case control study. In a case control study, we usually use something like the chi-square test to find statistical significance or an equivalent like Fisher's or something. And we use the odds ratio. Or there are various variations of the odds ratio depending on what kind of case control study you did, but we won't get into that right now. And then at the end, they have said sensitivity analysis, which is optional. Doing sensitivity analysis is good because it tells you that your finding is robust, even if you define the data a little differently, even if you try to adjust for factors like, gender or age or, number of years of illness. That's okay. Then they came to the results. Okay. The results have given a description of the sample. They've said 6,140 cases and 12,280 matched controls. Do these numbers look a bit suspiciously round to you?
Controls outnumber the cases.
Okay, controls outnumber the cases. That's a very good observation. But in a case control study, this is absolutely fine. In a case control study, you can have a case to control ratio of 1:2 or even up to 1:4 to improve statistical power. So you can have double the number of controls. Sometimes you can even permit up to 4 times the number of controls, provided you can recruit that many, because the larger the size of the control group, the better is the statistical power of your case control study. So this is good actually, having twice the number of controls. But have they told you anything about how they are matched? They said cases and matched controls. Matched on what variable? Yes, somebody called Dr. Avinash has said the number is exactly twice. In real life, because we don't always get a match for everyone, the numbers will not always come so even. You will not usually get a person saying 200 cases, 200 controls, unless you are taking, a very well-defined and very well-behaved population. Exactly double makes it a bit odd, not necessarily wrong, but a bit of a cause for concern. You will want to look at the other statistical analysis. And they have not told you how the matching was done. Then they tell you midlife hypertension prevalence was higher among cases than controls. Okay. They've told you how much percent it was in the cases, how much percent it was in the controls. Now, after this is ideally where your odds ratio should have come, but instead they have presented some logistic regression. Not very sure how they have done it, Yes, and somebody has said, sir has said that they should try to adjust for confounding factors. In a case control study, you should adjust not for too many confounders because that dilutes the result of your study, but at least for basic, well-known, well-established confounders like age, sex, and, common risk factors, body mass index, diabetes mellitus, dyslipidemia, the other vascular risk factors. Once you're saying something is a vascular risk factor and you want a vascular mechanism, you should at least have the other 3 or 4 common vascular risk factors. Now look at the next statement. In unadjusted analysis, midlife hypertension was associated with increased odds of AD. Do you see something very, very odd about these odds ratios over here? I've highlighted it, just zoom in on that. You see something odd about this odds ratio that they have reported. If you notice, the odds ratio is 3.45. But the confidence interval is, yes, exactly. The confidence interval doesn't include the odds ratio. And even if you assume that it's 1.45, it still doesn't include. Something is wrong here. Either they have copied and pasted a wrong value, or they have just made a typographical error over here. But this odds ratio cannot match this confidence interval. Odds ratio always sits within the confidence interval. Adjustment for education attenuated the association, and they're giving a credible odds ratio. 1.26 comes between 1.19 to 1.34. And it's fine to adjust for education because education is a protective factor against Alzheimer's dementia. The fully adjusted model showed a robust but modest association. Have they told you what is that fully adjusted model? They have. They have told you in the method section that adjusted model includes education, diabetes mellitus, dyslipidemia, coronary artery disease, atrial fibrillation, stroke or TIA, smoking, and BMI. You could get a little concerned about this because first and foremost, some of these exposures like atrial fibrillation would be quite rare. You usually want the exposures to be common and the outcomes to be rare. And second, stroke and TIA are not necessarily the same. And if a person has stroke and develops dementia, do you think the diagnosis would be Alzheimer's dementia?
Vascular.
Absolutely.
No.
Wonderful. So it would be either vascular or it would be a mixed vascular in Alzheimer's, which is also very common. But once you say that you're including patients with stroke, there is always somebody who can say, did you really diagnose Alzheimer's or were you diagnosing mixed Alzheimer's and vascular? So that is always an issue. And then they did sensitivity analysis. They have said for sensitivity analysis, they have looked at the effect of gender, age of onset, and there they have ruled out stroke, which is a bit odd. Since they have taken the trouble to go and find out stroke and then rule it out, this need not have waited till the sensitivity analysis. This could have been done in the normal odds ratio and adjusted odds ratio analysis. And they also found that in that sensitivity analysis, there was slightly stronger association among women and early onset Alzheimer's. So in other words, the risk of developing Alzheimer's in a person with hypertension in middle life appears to be higher in women than in men, and in those whose Alzheimer's disease is of earlier onset. Now let's come to the conclusion. Let's look at this statement. This study proves that treating hypertension in midlife will prevent Alzheimer's dementia in older adults. Does anyone want to comment on this? Fantastic. So it's exaggerated. That was something that even ChatGPT picked up. You do not say from one study that something has been proved. Even if your association is very strong, even if you've done a huge study with very good methodology, every result has to be replicated. All of us are aware of the replication crisis in biomedical science and in psychiatry in general. So, we should not make a statement like will prevent. And have we said anything? Is this study about treatment at all? Can a case control study say anything about treatment? They're not even saying the study proves that hypertension is a risk factor. That's still okay. Thought of excusable. They are saying this study proves that treating hypertension will prevent Alzheimer's. Can you conclude even a bit of that from the study? Impossible. Yes, because nothing has been stated about treatment. Now, when I come to the reviewing the review of literature and introduction, we'll see that there actually is a point to making the statement, but they have not made the statement in a correct way. So again, next slide. These findings show that hypertension is the main cause of Alzheimer's dementia. Would you agree with a statement like this? No, you can't agree with it. Not in a case control, not even in a cohort study. Even if in a cohort study you find this association, you cannot say it's the main cause. All of us might have read that beautiful Lancet document which listed out 14 modifiable risk factors for dementia. And if there are 14 of them, then hypertension cannot be the single main and should be aggressively treated in all individuals. Again, do you agree with this statement? What do we mean by aggressive treatment? There are some conditions like diabetes mellitus where you talk about aggressive treatment, aggressive glycemic control, or malignancy, you go for an aggressive induction phase followed by a maintenance phase, But do we talk about aggressively treating hypertension? We don't. Reading this conclusion makes us feel like we're watching a sports match or a wrestling match and not a scientific paper. So it's too dogmatic, too aggressive, too, on the nose, and we can't really agree with any of these statements. A better conclusion would have been this study shows that there is a significant association between midlife hypertension and the risk of Alzheimer's disease with an absolute risk, with a relative risk increase of whatever, 26% or 19%, whatever figure you want to take. And this risk may be stronger in women and in younger patients. Treating hypertension may be useful in preventing progression to Alzheimer's dementia. That would have been a very good conclusion. Now they have keywords, all that is fine. Let's come to the introduction. Again, let's look at the first statement. Alzheimer's dementia is increasingly viewed as a vascular disorder in which midlife hypertension plays the dominant role. Again, do you see? Yes, somebody has said correctly. Identifying it early may prevent, that's right. But it's not the single cause. Yes, someone has raised their hand. Keywords may be different from the ones in the abstract. That's okay. That sometimes it depends on what the journal permits. Some journals allow you to use your own keywords. Some will want you to pick from their list. So that varies from journal to journal. So again, here the statement is very, dogmatic. Is increasingly viewed as a vascular disorder. Now, if I were to ask all of you, what do you think Alzheimer's dementia is? What is the first word that would come to your mind? If I woke any of you up at 12 o'clock in the midnight and said, Alzheimer's disease is a dash disorder, what would you fill in the blank? Aging,
Neurodegenerative.
neurodegenerative, amyloid related. These are the kind of words, neuroinflammatory. These are the words that would come. But vascular would not be plaque exactly. So vascular is not the first word that would come. We do know now that there is some evidence that vascular factors contribute to the progression of this disease. But we cannot say that it is increasingly viewed and that midlife hypertension plays the dominant role because there are so many other risk factors for Alzheimer's dementia, genetics, family, ApoE4, apolipoprotein E genotype, various single gene mutations, and all those 14 modifiable risk factors that we talked about. Then they say that high blood pressure directly contributes to the onset of AD. Okay. Now, when they make a big statement like that and give a reference, it is always good to go to the reference and see if those people have really said that. What does this Iadecola and Gottesman paper say? It says neurovascular and cognitive dysfunction in hypertension. Does that title even contain the word Alzheimer's disease? No. It tells you that hypertension is a risk factor for cognitive impairment, which could be vascular dementia, which could be other dementia. So they're not even stating the facts from the paper correctly. They've provided a beautiful reference to a very good paper from a very good journal, but they've not represented that finding correctly. Then they say, although genetic factors such as ApoE4 remain relevant, hypertension has been recognized as the main predictor of dementia across populations, overshadowing other lifestyle and metabolic determinants. By now, all of you can see that this is wrong. But just to continue the game, let us look and see what this Livingstone et al. Paper says. What does it say? Livingstone et al., unfortunately, is the Lancet Commission report, Dementia Prevention, Intervention and Care. And any of us know that the Lancet report had 14 risk factors in it, not one. The Lancet risk factor report did not mention that hypertension is the dominant risk factor, which overshadows all the others, and overshadowing is a very literary word. It's not a kind of word that we need to use in a scientific paper. You can use it in a novel, Then we come to the next slide. Midlife, often broadly defined as ages 30 to 65. How many of you are below the age of 40 here? A lot of you? I'm sure there are some residents here. Senior residents, young faculty. Yes, some of you who are at the age of 30 or so. Would you consider yourself to be in middle age? Yes, usually middle age starts to start at 40 or 45. So this definition of midlife is again not correct and is considered to be a period where the brain is especially vulnerable to vascular injury. Is that true? Is the brain more resistant to vascular injury at younger ages and older ages and, more vulnerable only between the age of 30 and 65? We can't be sure. So again, they have cited a paper here. Let's look and see what this paper says. And this paper again talks about midlife blood pressure and dementia based on one study which was done in Hawaii. It does not again tell us that all middle-aged people are more sensitive to develop dementia if they get hypertension. The next paragraph is all about the neurobiology. As far as this goes, this is quite accurate. Hypertension causes microvascular damage, impairs blood-brain barrier integrity, causes neuroinflammation, and this may accelerate amyloid deposition, etc., etc. All that is fine. Now, the next line again is a cause for concern. It says, some neuroimaging findings show associations between hypertension and structural brain changes. Now, if hypertension causes structural brain changes, does that mean that this is because of Alzheimer's dementia or because of something else? Exactly, because many other kinds of dementia can have cortical atrophy, temporal lobe atrophy. So, this statement alone does not really tell us that hypertension is specifically associated with Alzheimer's disease. So, when you read an introduction like this that contains a lot of questionable or dubious statements, one of the first things that you can do is you can open PubMed and you can look and see if there are any meta-analysis or systematic reviews linking hypertension with Alzheimer's disease. And what do we find? There is one. Okay. This was, of course, published 7 years ago. So I'm still in 2025. This was published 6 years ago. And it's Midlife Hypertension and Alzheimer's Disease, a systematic review and meta-analysis. So this is the kind of paper that you would want to cite right at the beginning when you're writing your introduction. But it doesn't appear anywhere in the reference list of this paper. So when you write an introduction for any original research, you have to justify doing the study based on the prior literature. And if someone has already done a systematic review or meta-analysis, the first thing you should do is cite that. Why? Because that will tell you a lot of things that you may not pick up if you just use your imagination. So let's look and see what the systematic review found. They found 7 studies and they found something very interesting. There was a significant association between systolic BP more than 160 and Alzheimer's. For systolic BP more than 140, there was a smaller association, but again, p-value is just borderline. For diastolic hypertension, there was no significant association, and the studies were heterogeneous. They were probably not of very good quality. They could not be, joined together. So again, if the authors had done their homework, if they had opened this systematic review, which is available, you can download it free online, and looked at, or even looked at the abstract, they would know that if they want to do a case control study, they would not only have to do the study, they would also have to stratify it based on how much the blood pressure was elevated, whether it was systolic or diastolic blood pressure that was elevated, or both. So already there's a missed opportunity that we can see here. And if you do the same search, if you keep searching for papers on Alzheimer's disease in relation to hypertension, you will also find this meta-analysis, which was published 4 years ago, which talks about how antihypertensive agents reduce the risk of Alzheimer's disease. And not only that, but antihypertensive agents differ in their potency in terms of category. So overall, antihypertensives reduce the risk of Alzheimer's by just a little bit, 0.9, around 5 to 10%. But if you take angiotensin 2 receptor blockers, losartan and similar drugs, then the risk reduction is much more, comes out to around 22%. So this is something that should have come in the introduction. This is something that should have been factored into the methodology, because then when you're doing your sensitivity analysis, you can stratify according to the BP recording. And when you're doing your sensitivity analysis or, adjusting for confounders, you can also adjust for what type of antihypertensive medication the person was taking. Because we know that if they're on on AT2 receptor blockers, they are going to be more protected against Alzheimer's, even if they are hypertensive. So we have to correct for that. Otherwise, we will underestimate the association between hypertension and Alzheimer's dementia. All right, let's continue with the rest of this paper. So we have already seen that in the introduction, there has sort of been a missed opportunity because we did not really, the authors or the researchers who have done this study did not really look at the prior literature and see some very important relevant findings from systematic reviews and meta-analysis. Now let's come to the study design. So they have said that this is a nationwide retrospective case control study. Do we need to say retrospective case control study? Are there prospective case control studies? There are. Yes, so they do need to say that. And they've said nationwide, of course, because it is an anonymized manuscript for peer review. They have not mentioned the nation or the center, but we can assume it is some particular country. And they have mentioned health and administrative registers accessed through such and such data. Okay. Is that a good source for data for a case control study? What are the advantages and disadvantages of using a registry as opposed to using patients? People who come to the hospital or people who are in the community. So Sir says, no, we should not use a registry. You can, but there are disadvantages to it. There are drawbacks to it. And what are the drawbacks to that? The data is inadequate. Absolutely. It would be like basically what we are doing would be more like a chart review. We cannot really call it a proper pure case control study because in a case control study, you have to interview or interact with or give a questionnaire to the patients themselves. Whereas here you are relying on electronic medical records or registries. It is basically more like a chart review than a case control study. So right away, we have a big problem. Should this be called a case control study or should it be called a register-based study, which would be more accurate? Then they have said the study included residents aged 65 years or older who had continuous registry coverage for at least 10 years before the index date. Are you okay with this? When does midlife start? All of you said midlife cannot be exactly. So if midlife is defined as over 40 or over 30, then you need data dating back to 35 years or 25 years. Getting data from 10 years behind will only get you maximum data from 55 years and above. And that is already crossing the end of midlife and going towards later life. So this data source is flawed. There is a problem here. They should have included people who had retrospective data for at least 25 years to get to the age of 40. Okay, the observation period spanned so and so, and individuals were excluded if they lacked sufficient follow-up or had emigrated. That is fine. If inadequate data is there, you have to exclude them. But again, if you are dropping out a lot of cases, what should you do? Like supposing your patients drop out in a clinical trial, what do you do? Exactly. As Sir said, how do you handle missing data? You should at least make an effort to see that the people who were left out or who were dropped out of the study were comparable to those who completed the actual study. Otherwise, there's a kind of a bias there from the very beginning. The sample is not representative of the general population. Then they have said cases were adults aged 65 years with a diagnosis of Alzheimer's dementia with confirmation by a neurologist or psychiatrist. Again, we see the same problem as in the abstract, which is the criteria have not been mentioned. It's good that they took records only where the neurologist or psychiatrist have made the diagnosis. But if they are relying on ICD codes for hypertension, and if ICD codes are there in this registry or in this electronic medical record, you should be able to pull up the ICD-10 code for Alzheimer's dementia, which is, does anyone know the ICD-10 code for Alzheimer's? Okay, homework. It's actually very easy to remember, but I will leave it as homework for everyone. So, and they have said that they have left out people who got an other diagnosis of dementia, frontotemporal, Lewy body, Parkinson's disease, etc. And again, this issue of 10 years data is not enough to really capture hypertension in midlife. Okay. Then they have selected 2 controls for each case using risk set sampling. What does this mean? So when you come across a term that you don't know the meaning of, it's always good to look it up, So if you have a doubt at this point, it's always good to pause and look up and see what is risk set sampling. But as we said at the beginning, it is a good practice to have more controls than cases because that improves the power of your study. Controls were matched on, I'm sorry. They go on to say controls were matched on age, sex, geographic region, and duration of registry follow. Controls had no dementia-related diagnosis or prescriptions at any time. Again, is there anything else that you want to leave out that could have been done here for the control selection?
Sir, I'm sorry to interrupt, but we have another 20 minutes for the session, sir.
No
And
problem.
10
We will come to it soon because we have already discussed a lot of it while going through the abstract. We will complete. So
Yes, sir.
midlife hypertension, the
Thank you,
definition
sir.
seems to be good. They have given ICD-10 definitions. But again, 6 months of antihypertensive prescription, is it a good criterion to define hypertension? Can people take antihypertensives for other indications? Yes. So a person can take beta blockers, for example, for portal hypertension or for anxiety disorder. People can take certain antihypertensives for congestive cardiac failure, even if they are not hypertensive. So this last criterion is not a good way of diagnosing hypertension. Covariates seem to be quite okay. We already saw that in the abstract. Statistical analysis, again, we would want to start with a normal ordinary odds ratio rather than a logistic regression. Now, and they have said descriptive statistics compare the characteristics between cases and controls. That is a standard practice. You want to know if the cases and controls are roughly comparable. Ethics and data access approvals is more or less written quite written appropriately. Informed consent obviously cannot be obtained because it's a register-based study. So here again, they're telling you this many cases, this many controls. And again, here you see the problem. The mean age of patients was 76.8. So if they asked only 10 years data, you would have data only till the time they were 66. We would not really have much data about whether they had hypertension in midlife. They may have had, but we only know if they had it at around the age of 60 or 65. Then if you look at the tables in the text, you see that the two groups differ on certain other variables like education, vascular risk factors, and so on. If you look at the exclusion criteria, for the cases, have they mentioned vascular dementia as an exclusion criterion? They haven't. So again, that's a big flaw. We want vascular dementia to be excluded in the study. It has to be excluded because that is the main type of dementia associated with systemic hypertension. It has to be. We already looked at these odds ratios when we were looking at the abstract. And then here you see the table 1 is basically the table that you write at the beginning of all our dissertations. If you have two groups, are they comparable in terms of education, diabetes, age, gender, etc.? Logistic regression, they have already presented in the abstract, And if you look at the sensitivity analysis, this is an interesting part. This is something good that they have done, That is, they have tried to see if we exclude patients with certain conditions, or if we stratify the risk in terms of only for women or men, what kind of value do you get? This is good. This part, however, was not good because they should have tried to exclude patients with stroke right at the outset, to avoid any kind of confusion, especially if you look and see that in this group of so-called Alzheimer's disease cases, 9% had stroke. So it may be that 9 to 10% of these cases were not pure Alzheimer's dementia. They were Alzheimer's with vascular dementia. Again, making your results a bit of a mess. If you look at the discussion, again, it has many of the same flaws as the introduction. Robust evidence that hypertension is significantly associated, independent of all this. Yes, it does provide evidence that it is significantly associated, but you should not overstate the case. Again, because registry data may have been lacking, we cannot be sure that it is really hypertension at the ages of 40 to 55. Biological plausibility is absolutely fine. They've talked about endothelial dysfunction, inflammation, lymphatic system dysfunction, which is a recent concept. So that part of it is absolutely fine. But again, if you look at this one line, neuroimaging findings show that individuals with long-standing hypertension exhibit white matter hyperintensity burden. Again, white matter hyperintensity is associated with what kind of dementia? It's vascular dementia. Exactly, subcortical, vascular, multi-infarct. You don't want to mention that as a significant finding if your contention is that it's a risk factor for Alzheimer's dementia. You could talk about hippocampal atrophy. Yes, that is associated with Alzheimer's, but white matter hyperintensity is not. In fact, it's linked with some totally different kind of dementia, vascular. So our study adds to the body of evidence is actually a good part. This part is well written. They have not said it is the one cause or it's the only cause. They have just said it adds to the body of evidence. It supports models in which chronic vascular dysfunction contributes to neurodegenerative processes. So this paragraph is good. This paragraph is sober. It's well written. It matches the scientific evidence as well as the findings of the current study. And they've talked about other risk factors like gender, educational status, and all, which we know are risk factors or protective factors for dementia. They have mentioned its major strengths being the sample size, the long follow-up period. Again, I would disagree. The follow-up period was not adequate if your interest is in midlife dementia. national coverage, and reliance on specialists confirmed. But again, they did not mention by what criteria specialists made these diagnoses. They've used multiple registries. They have done matching. They have done some sensitivity analysis. So all that is credible. Regarding limitations, they have mentioned that they cannot capture undiagnosed or intermittently elevated blood pressure. Is that likely to be a significant risk factor for dementia? Brief elevation of blood pressure? Supposing my blood pressure is elevated because I have to give this presentation, or my blood pressure is elevated because you are listening to me give this presentation. Would that be a risk factor for dementia? I hope not. I hope I'm not increasing anyone's risk of dementia. So that's not really necessary to mention. They have mentioned lifestyle factors like diet, physical activity, sleep, alcohol use. That I agree, those are important, were unavailable. But you really think data on alcohol use would have been unavailable in health records? They've got data on smoking. What prevented them from getting data on alcohol? That looks like a bit of an excuse to me. Probably they forgot to do it, or they did not think of doing it till the paper was ready to be sent for publication. A registry that contains data on smoking is almost certain to have data on alcohol as well, And they've made a very good statement here that despite extensive adjustment, this is an observational nature, and so it limits causal inference. Then they have said at the end that it has important public health implications because it's a highly prevalent risk factor. See, when we want to prevent a disease in the population, we want the risk factor to be something common. A risk factor that is very rare is not really useful from a public health perspective. So they're absolutely right in saying it's a prevalent factor and you can treat it in midlife. They have cited some clinical trials which say that blood pressure management may reduce cognitive decline. Again, note the word cognitive decline and go back and look at the Sprint Mind study. What does the Print Mind study say? Does it talk about Alzheimer's? No. It says effect of blood pressure control on probable dementia, which could be mild cognitive impairment, which could be vascular dementia, which could be anything. So again, not a very good study to cite in this context. So midlife hypertension, again, notice here they've completely forgotten about Alzheimer's. They've said it can be incorporated into dementia prevention strategies, which may be correct, but which is not what they stated in their title and not what they stated in the aims and objectives of the study. By the way, did you find an aims and objectives section in this manuscript? Was there one? It was stated in a very broad way whether midlife hypertension is associated with a higher likelihood of Alzheimer's disease in older adulthood. So sometimes even if a paper doesn't have a separate aims and objectives section, that's fine. The aim or objective will usually be the last sentence of the introduction, will usually be the last sentence or last two sentences of the introduction. And again, let's look at the conclusions. This is a significant and independent predictor. Okay, may represent an actionable strategy. Now look at this. Future research should integrate genetic, neuroimaging, and biomarker data to clarify mechanistic pathways. Do you think this is a statement that needs to be here? They've already cited a lot of studies saying that it affects the endothelial cells, it affects the lymphatic system, it affects neuroinflammation. So do we really need future research on all those things? You may want to know which gene is associated with increased vulnerability or whether it can be identified at an early stage, but that should be stated more clearly. Then the next statement they make is prospective trials evaluating whether blood pressure management can prevent cognitive decline would be valuable. Yes, that would be. And ultimately, a comprehensive approach combining vascular modification with strengthened cognitive result may be the most effective means of reducing the global burden of dementia. Again, note they've forgotten about Alzheimer's. They've moved into a general discussion about preventing dementia, which means they sort of lost focus of what their original aim is. The conclusion should match the aims and objectives and results of the study. And again, if you see this particular statement, can slow or prevent cognitive decline. Again, it's not the same as Alzheimer's dementia. So, summarizing, how many things have we found in this paper that, needed to be corrected or need to be revised? Pardon, sir? You have asked a question there. Oh, absolutely not in this paper. So you can put your mic on. We will discuss this. You mentioned something here.
Professor Madhukar?
So you made a comment here, absolutely not in this paper.
Madhukar sir, you can unmute and speak.
All right. While we are waiting for Sir's inputs, maybe I will end by just telling you what could be one of the peer reviewers' best friends when they are going through a case control study. And this is yet another error that you could find in this paper. Okay. What does it say right at the beginning? It says this is the Straub statement, which is a checklist of items that should be reported for case control studies. Did the authors of this paper mention the Straub statement anywhere? Did they use that Straub flow diagram to describe how many cases were screened, how many were filtered out, how many were finally included in the analysis? No, they did not do that. So that's yet another issue. Nowadays, more and more journals insist that based on the paper, you have to follow the appropriate guidelines. So if it's an observational study, like a case control study, you have to use Straub. If it's a randomized control trial, you have to use the guideline for a randomized control trial and so on. So this is, again, when I was talking to you a few weeks ago about reviewing systematic reviews, we talked about how when we forget, and when AI misses out, the checklist can always be a very useful tool. So this checklist will tell you, what things you need to look for. So was the term case control study used? Was the abstract informative and balanced? Was there a rationale for it? Did they state the clear objective or hypothesis? Was the study design described? Did they give clear case criteria and for eligibility and ascertainment of both cases and controls? How did they do the matching? Did they define all the exposures, confounders, etc.? Did they use specific diagnostic criteria? How were the variables measured? And this again is a limitation of registry data. Data from a patient can be obtained in a number of ways, with a scale, with a scan, with a BP measurement in the office or in the clinic. But registry data is just limited. And how was bias addressed? That's very important, because suppose there's a nationwide registry, but this registry captures mainly people from urban areas, or mainly well-to-do people who are able to have access to electronic health records, whereas people from a lower socioeconomic status don't have access to it. Then the sample itself is biased. It's not representative of the general population. How did the sample size or study size get calculated? That depends on what you're trying to answer and what the previous literature says. Statistical methods. Was there a clear description of the participants, including a flow diagram that was missing from this paper? Were the results mentioned, adjusted, unadjusted? Were the relative and absolute risk stated? No, they only mentioned the odds ratio. They did not mention the absolute and relative risk increase over baseline. Were other analysis done, like sensitivity analysis? And in the discussion, key results, limitations, interpretation, and generalizability. That again was something that was sort of missing from the study. They said it's a nationwide registry, so it's generalizable, but they did not tell us how sometimes data from a nationwide registry may not always be that generalizable, if it's incomplete in coverage, or if it covers only the most recent years, or the last 10 years, or the last 15 years. And of course, at the end, you do need to talk about funding and conflicts of interest. So to sum up, I'm sure all of you will have your own inputs and comments and questions to, to add here. But to sum up, when reviewing a study of this sort, or any sort for that matter, the first step is to familiarize yourself with the study design. If you're already very familiar, or if you've recently done a case control or randomized control trial yourself, please, that's fine. You need not read more. But if you're not, it doesn't hurt to go back and look at what your textbook said, or what WHO says, or what ICMR says. Then read through the paper line by line carefully. Don't assume that you can just look at the abstract and come to a conclusion, or just look at the results and discussion and stop there. No. Each line may tell you something that was done right, that was done wrong, or that was just missed out and that had to be, corrected later on. And when in doubt, always keep this checklist near you. Finally, one word of encouragement for all of you. I think if we go back now to our AI review, you will find that instead of this being, a strong in design and execution study, we will find that there were a lot of issues with the design and execution. And that as an editor, if this paper was sent to you and you got this peer review report, would you say that, this is a strong study that just needs a few minor revisions? What would you say? Would you reject this paper if you were the editor? Would you say, no, this paper is not good, I will reject it? Exactly. So I think at the end of this paper was very cleverly designed by the team. I really congratulate them to be a paper where you need a lot of major revisions. But if you just do a surface level reading, as our chat GPT has done, you will only come up with a conclusion of minor revisions. This paper would need major revisions. It would need the title to be changed, the abstract to be rewritten a little more clearly, the background to include the two meta-analysis and to avoid categorical statements, the methodology to include clear definition of cases, controls, diagnostic criteria, why alcohol was not available, why they took only 10 years data back, why was it not look back to the actual period of middle age. The results, again, would need to be presented in a way that corresponds with the methods. And the discussion and conclusions would need to be written in a more balanced way that reflects the study findings and that does not include vague statements like more research is needed or more imaging studies are needed, because this paper doesn't really touch on imaging or, genetics as such. So in conclusion, by going through these steps, by going through a paper line by line carefully, looking at both the strengths and the weaknesses, and having not only the checklist with you, but also a strong concept or template in your mind of what a case control study is supposed to be, any of us can do this review. And I'm sure you will all do a fantastic job if you are given a case control study to review in future.
Sir, we also request you to give a few tips on peer reviewing RCT studies, sir, as RCT will be given as assignment to the participants.
Absolutely. Thank you, Abhivak. I was just coming to that. I was just worried that we were a bit short of time, so I did not really talk about that. But you're absolutely right. We are going to talk about that a little bit. And so when we talk about a randomized control trial, again, what is a randomized control trial? So like we talked about what a case control study is, what is a randomized control trial? You are going to use an intervention. You're going to randomize a group of study subjects into two groups. The purpose of randomization is to ensure that the two groups, are sort of comparable. Even if they are not matched, they are sort of comparable. And so any variation that you find in response between the two groups is due to the treatment and not due to any other variable. Then the randomization has to be described, the allocation concealment has to be described, blinding procedures have to be described, and then you have to follow standard guidelines. So all of us may remember this particular checklist. This is like we have the strobe guideline for case control studies or other observational studies. You have the consort, and consort was just updated last year, So you can just keep this next to you as you, read through a randomized control trial. Again, starting from the title, is it clearly described as randomized? Again, if it is randomized, is it randomized and double-blinded or single-blinded? Is it, a multi-center study or a single-center study? This abstract should give a structured summary, again, using that same description, the IMRAT, Introduction, Design Methods, Results, and Conclusions. In a clinical trial, you have to mention certain details that are not required for an observational study, like clinical trial registry, where the trial protocol can be accessed, either in CTRI or any international trial registry. Ethics committee clearance, informed consent, conflicts of interest, sources of funding are very important in an RCT, especially if the treatment being given is something that is related to your funding source. Then is the data being shared? That's very important nowadays, because it is said that the data has to be made accessible to not only researchers, but even to the public. Are there any conflicts of interest? Then background and rationale. Again, the review of literature should include recent literature on why you think this intervention would be useful for this particular condition in this particular population. And this is something new that, we tend to neglect, but that we should be aware of, which is that nowadays there is a tendency, there is a trend that we have to consider the consumer, namely the patient or the client, when we are designing a randomized control trial. So was this just something that some doctors sat together and designed, or a pharma company designed and, just told the doctors to do it? Or were patients with this disease involved in designing and, contributing to the design of the trial and on the reporting of the trial? Then type of trial. There are many types of trials. There are parallel group trials. There are crossover trials. There are trials where there is an initial placebo-controlled group followed by a open label group. How was the sample size calculated? And what was this purpose of the study? Was it to show that the two treatments are equal, that one is superior to the other, that one is not inferior to the other? All of these have different implications as far as the data analysis and sample size are concerned. So for example, if you want to show that two treatments are equal, the sample size may not need to be that big. If you want to definitively show that one treatment is better than another, then you will need a much bigger sample size, sometimes which is difficult to attain in practice. Then what are the inclusion criteria? Where were the patients recruited from? Was there any change that was required to the protocol, after the study was started due to any unavoidable reasons? If it was a multicentric study, description of what was done at each study. What was the primary outcome? This is something that's very important. If a study says effect of this thing on negative symptoms, then the primary outcome has to be negative symptoms. They cannot later on say the study was effective at reducing depressive symptoms in schizophrenia, and so the drug was effective. No, if the primary outcome was negative symptoms, the primary outcome variable has to be some scale that measures only negative symptoms. And how was it defined at each time point? Also, all clinical trials have to discuss harm, side effects, adverse drug reactions, severe adverse reactions. And surprisingly, it may surprise you to know that, it may surprise you to know that harms need to be reported even in other trials, like psychotherapy trials. Sometimes in a psychotherapy trial, patients may experience worsening of symptoms during psychotherapy. They may experience anxiety or panic attacks or suicidal thoughts. And, that is something that you have to mention. So harm always has to be assessed. And if it's not being reported by the authors, then you have a problem. How is the sample size determined? If a study had to be stopped prematurely, but you're still writing it up, then why? Why was it stopped? Was it stopped because the study became unblinded? Was it stopped because a serious adverse event emerged and you had to discontinue the trial? Why was it stopped? Then again, the details of randomization, allocation, concealment, blinding, which are all described very well elsewhere, but, you need to check if they are there and what statistical tests were done, which include subgroup and sensitivity analysis. And be very careful that the authors are not presenting subgroup results as the main result. Subgroup analysis can be done in an RCT, but they should not be hyped up or pushed forward as the main result. Then the results, which have to include that typical consort flow diagram, the recruitment, the number of participants who are randomly assigned in each group, baseline details for each group, number of participants with analysis, how were dropouts handled? If patients dropped out of the control clinical trial, how was that done? And how was the data analyzed to, address people who dropped out? What was the interpretation of the results, including all harmful outcomes, adverse effects, and what were the limitations of the trial? So just as you did with the case control study, by knowing what a case control study is and keeping the stroke guideline next to you, you can do a very similar exercise, a very similar thing. And in fact, I would suggest that, even today or tomorrow, you take the paper that the team has given you, which is an RCT, a model or a simulated RCT. And even if you don't want to sit and go through it line by line and torture the paper as I have done now, just take the consort checklist, keep it next to you, and just tick and see what was in the paper, what was missing in the paper, what was incomplete or only partially covered in the paper. You will be surprised that by the time you do this exercise, you will have at least 3 to 4 paragraphs of peer review report already waiting to be written. And finally, at the end, when you're submitting the report, remember that the journal style also matters. Like I said at the beginning, some journals want a very structured report. Like if you go to Springer Nature, for methods, you have to give something. For introduction, you have to give something. For discussion, you have to give something. Whereas if you go to Elsevier journals, they just give you a big box and say, type everything in there. And you have to provide your own headings or structure. So always look at the journal's peer review system and familiarize yourself with it before submitting a review and before submitting a recommendation. So I'll stop here. I think we are, we are running a little short of time. So thank you very much for joining me today and for, listening in on this discussion. I hope that this was useful. And, I hope that the next time you get a chance to read a case control study in a paper, you may, now open your third eye, the third eye that every peer reviewer has over here, and use it to see whether it really was a good case control study or not. Thank you.
Thank you, sir. It was a very comprehensive session wherein you took us through all the sections of manuscript and discussed regarding various problems in the manuscript as well as some of the positives. And all our participants were also interactive throughout the session. They have sent in their inputs and they were able to understand all the details. Um, yeah, I think many of the clarifications were done during the session itself. And thanks for giving us all the tips that is required for their assignment. So all the participants are requested to go through a randomized control trial, which is the second manuscript shared with you all. And with the consort guidelines, you can go ahead with that, and it will be discussed on the second day of the workshop here. Thank you so much, sir. Uh, Thank you, Dr. Saraswati ma'am, for moderating the session. Um, I request Dr. Anil Kumar sir to give the concluding remarks.
Hello, everybody. Grateful to Dr. Ravi Philip Rajkumar for his time today and the comprehensive analysis of the case control study, as well as a brief summary of the consort guidelines for RCTs. Definitely, this is an apt primer for all of us to begin the workshop on Saturday. Man behind all this, Dr. Vijay Herbishetter is missing today. He's busy with some other meeting. But happy to see a very active participation also from many of the participants today, and eager to meet you all during the weekend workshop. Thank you again, sir. And I also thank the moderators for their smooth moderating of the session today. Over to Dr. Shanteri. Thank you.
Thank you very much,
Thank you.
sir, and thank you, Saraswati ma'am. It was a really good experience, and I think we all learned something. And I also learned that all of you have also got your eyes mostly open. You just need to open it a little wider. Most of you were able to pick up a lot of the limitations in that paper before I did. So that's really a good job.
Thank you, sir. Thank you everyone for joining the session. So we'll be seeing you all on Saturday here in Nimhans for the 2-day offline sessions. Um, Thank you, one and all. Thank you, Dr. Anil Kumar, sir. Thank you, all the mentors and resource persons. Thank you for preparing this material for today. Yeah, thank you, sir. I
Thank
think
you.
we end the meeting.